Hi everyone, it's Lisa Moeller with MedMark Media and welcome to another edition of DocTalk Dental. We are so pleased to have two trailblazing endodontists with us on this episode today, Dr. Eric Herbranson and Dr. John Khademi. Dr. Herbranson hails from San Leandro, California with his practice Modern Endodontics Care. He has been a driving force in endo for the past 35 years. Dr. Herbranson teaches various seminars, lectures, and is passionate about endodontics and saving teeth. Dr. Khademi visits us from Durango, Colorado, where his practice Four Corners Endodontics is located. He is a pioneer of RDE, lectures internationally about the importance of CBCT, and has an over 25-year background in medical radiology that allows him a perspective shared by very few dental professionals. This is going to be quite the information-packed episode with these two experts. Welcome, Drs. Herbranson, Khademi. How are you?
Thank you.
Thank you for having us.
Welcome.
This is my second time.
I know.
And you said I could come back, but I had to bring a smart guy with me. So
We're all out of that, so you brought me.
John's the smart guy, so
I'm so
have at him.
happy that you took the invitation. Thank you so much
You're
for being
welcome.
back with us, and welcome, Dr. Khademi.
Thank you for having us.
So let's talk endo today.
All right.
You two are on the cutting edge of. You've been in the industry a long time, both of you.
Some longer than others.
Right. Well, Dr. Herbranson has been somewhat of a mentor to you, yes?
Absolutely.
Yeah, kind
Yeah,
of
I
both
was
ways.
Very fortunate.
Our relationship is one where we actually don't know who the mentor is, so which is good.
That's
right.
That's awesome. So, in you guys' opinion, how has endo changed in the last 10 years? Dr. Herbranson?
Wow.
That's a big that's a big question.
Big loaded question
Yes.
there. We ended up for a long time having a very slow evolution of endodontic thought. We had, this improvement, microscopes came in and nickel titanium files come in and that type of thing. And my influence has always been on the peripheries of endo, but about 12 years ago I realized that we had gone down a direction with our accesses and shaping where we were actually damaging teeth. And so I sort of, along with John Khademi and David Clark from Tacoma, the three of us kind of got together and said, this is not correct. So we kind of jumped into trying to fix one of the core issues in endodontics. And I got to tell you, it's been a real ride, because we had very quick adaptation from a lot of people, and surprisingly to me, we had a tremendous amount of resistance from a lot of people. Mm-hmm. And that project, if you will, this trying to redefine what a good access is about, and we can talk about that in a minute, kind of opened up a floodgate in a whole lot of people where they said, well, if you can challenge that, because it was one of the big one of the big deals with us, you can start to challenge other things. And now everybody's questioning everything. We're getting more technology.
Right.
Microscopes aren't new technology anymore. Now it's cone beam CT machines, and there's some stuff sitting on the horizon right now, near stuff and further stuff that's going to change it. Endodontics is going to be radically different in 5 to 10 years, I think.
I can only imagine. I mean, having an endodontic publication and going to all the trade shows that we do and seeing the new technology coming out every year, it's just mind-blowing what's happening. What about you, Dr. Khademi?
So the bulk of the thrust of endodontic technology has been addressing what endodontists think the purpose of endodontics is, which is to prevent or cure apical periodontitis. So everything that we've had, all the technology that's been introduced, has primarily been targeting that as the treatment objective of endodontics. And what Eric brings up really is a fundamental philosophical shift that's happened in the past dozen or so years, that what restoratively driven endodontics is, RDE, it's a shift away from that's the purpose of endodontics. A shift away from the purpose of endodontics is to prevent or cure apical periodontitis, because we just don't do that. Our best research says that doesn't happen. And what the shift is a shift to what the real purpose of endodontics should be, which is to restore the tooth.
Right.
Hence restoratively driven endodontics. And so what a lot of people are looking at the technology through the lens of is how can we better accomplish the objectives that endodontics has always had. And we're actually redefining what that objective is. And sure, we'd like to prevent apical periodontitis. We'd like to cure apical periodontitis. But our focus has damaged the tooth in the process of fixing it. And we've left people with little or no disease based on what we see on the radiograph, and then a broken tooth 7 years later. And that doesn't make anybody happy.
Yeah, no, that's no good. So what would you say the role of the new and latest technology, what does that role play in your thought process treating endo these days?
Technology helps us do things better, more efficiently than we've done them in the past. Okay, and nickel titanium files were on the second, third, fourth, fifth generation of these things. They're heat treated, they're soft, they go around corners. Corners just are not an issue anymore in a canal. It used to be 40 years ago. It terrorized you. Now you can go around a 90-degree bend with no problem. You can see better now because we're using microscopes. The CBCT machines give us literally Superman vision, so you can see inside the tooth, you can see anatomy. That is not to be discounted at. It's an enormous advantage. There's some new stuff coming down the pike, some new irrigation systems. There's some new canal locating devices that John's been working with that we need to talk about. But all of those are tools to allow us to do the process, the traditional process of endodontics better and more efficiently. And the traditional process is to clean, quote, shape, quote, and pack the canal to get rid of this canal space. Mm-hmm. What John's talking about is a philosophical change in the way we actually look at this triumvirate. Because the elevator version of what's endodontics is you get rid of the pulp, you clean it out, you stuff a filling in there, and it heals itself.
Right.
Well, that's a pretty simplistic viewpoint. It's not really accurate, but it kind of works for everybody. What we're saying is that you've got to take a couple of steps back, and you've got to start looking at more sophisticated diagnosis. You've got to start looking at more sophisticated treatments, and you have to do it from the perspective of the whole patient.
Right.
You know, the patient isn't being served if they lose the tooth because your process weakened it and it broke. Your patient isn't being served if they walk into you and they go, gee, I've got this and this and this going on, this weird pain going on, and really what they've got is sleep apnea.
Mm-hmm. Exactly.
You know, I mean, you have a magazine on sleep apnea,
yes.
and so we're seeing guys talking about occlusal trauma. We're talking about the effects of that, the psychological things, the sleep apnea, and dramatically increasing the scope of our diagnostic skills, which it doesn't have a whole lot to do with this triumvirate of needs that we've traditionally spoken. So what's happened is we are just sort of expanding and taking a couple of steps backwards, and we're becoming more doctors, not technicians. And the technology supports all of that. So John can maybe expand on that a little bit, because he's been involved in, especially with the cone beam. He just got a little free advertisement here. He just got done publishing the definitive text through Quintessence on CBCT imaging for endodontists. And in my humble estimation, without brown-nosing him too much, is it's a landmark book, because it explains it not only from a technical standpoint, but it gets into the cognitive areas that can fake you out. It gets into the research and where your biases are, and it gets back down into how you can use that as a diagnostic tool and all of the issues along with that. I think everybody should read this thing. As far as I'm concerned, it should be mandatory for graduate programs.
Yeah. Sounds amazing.
It's a great publication.
Thanks, Eric.
He's older than he used to be, but now that he's put the work into that. Yeah.
And an author. That's amazing.
Author, yeah.
That's amazing.
Famous
well,
author.
it seems that you two are kind of shaking the endo snow globe, if you will, So tell us, Doctor, what your opinion is on all this.
So the common perception of advanced technology is it allows you to do more. And actually, I think it allows you to do less. And so with advanced imaging, you can find things that are on the edge of normal that can be reclassified as disease. And some people think that that's of benefit, and other people think that maybe with advanced imaging, for instance, cone beam CT, we may be better off actually monitoring some of these. And medicine is seeing the same kinds of things happen, that with advanced imaging you can find smaller and smaller cancers, and that reclassifies whole groups of patients that probably would have been fine for their lifetime into a diseased status, and results in a lot of overtreatment.
Right.
So what the technology I think is allowing us to do in endodontics, especially cone beam CT, microscopes, these new heat-treated nickel titanium files, it's actually allowing us to do less. We don't have to treat everything. Sometimes you're better off actually leaving something behind than, you know, shall we say, killing the tooth in the process of treating it.
Right.
So our accesses can become actually smaller with the microscope and smaller with the cone beam CT, and our shapes can become smaller, so we're actually doing less than we would have traditionally done, as opposed to the old way of thinking would be, we have all this technology, we can do more. And the new way of thinking is we have all this technology and we can actually do less. We can cut less tissue away, and we can also not cut tissue away on some people who don't need it cut away.
That would be a positive in my book. Definitely.
Yeah, I mean, it's not just dentistry that's going through these big shifts in overdiagnosis and overtreatment. Medicine is too, and actually medicine is considerably ahead of us in overdiagnosis and overtreatment. There are conferences on this topic now about with advanced technology, the common perception is we can do more, we can catch things earlier, but actually with advanced technology you can do less.
Very interesting. So let's talk about SS White and the V-taper.
Oh,
I know both of you are fans.
There's a story there about 12 years ago, I guess, roughly. John David Clark, who's a super generalist from Tacoma, Washington, wonderful guy, and myself came to the same conclusion at the same time, kind of separately, that the paradigms that we had in endodontics is we were actually over-prepping teeth and damaging because of that. Clark came at this from the restorative standpoint. Teeth were breaking. I came to it from the tooth anatomy standpoint because I'd done all this work on the tooth atlas, and I had a really profound sense of what the anatomy was. And it dawned on me after seeing some cases that were done by very caring, skilled people that didn't come out well, that there was a fundamental misunderstanding of what this anatomy was like. And
the root anatomy.
The root anatomy. It's like there's many more concavities than people think. And they didn't have really a really detailed version of this. And the file systems that were the most popular then were too fat. So
and still the most popular.
Still the most popular, and they're still too fat. So we came together and went, gee, we need to kind of hopefully fix this, you know, or is there something we can do about this? And I actually talked to one of the big manufacturers way back in the day about changing their file systems. I gave them dimensions, I gave them a name, and they told me to take a hike because they were making so much money off of the file systems that I was criticizing that they didn't want to hear about.
Right, yeah.
Well, along comes, just out of the blue, SS White. They wanted to get into the endo market, and there was a file system that had been developed by Chuck Goodis in New Mexico called the V-taper system that actually addressed a lot of these issues. And so we were influential in getting them to adopt that particular file design. We wanted it because we wanted to use it clinically. But we told them, look, this is a great file system. They're strong, they're tough, they're efficient. They answer the problem of over-prepping these teeth. And we think there's a market message there that you can, and they bought it, and bless their soul that they did, because now that system it's a very effective system, and it answers the issues of over prepping these teeth.
Mm-hmm.
I'm surprised how much pushback we got on this message when we really sat down and started really talking about it.
Really?
Yeah, I was.
We're showing follow-ups with working cases. The patient got better, the bone grew back, the sinus tract healed,
Right.
and we have endodontists saying you can't do that.
Why?
It's not opened up enough, and you're like, they got better. Yeah.
Isn't that the point?
Yeah.
No, it would seem.
But it's staggering to me that these guys can go through all the education they've gone through, have the experience that they've gone through, get confronted with an idea that is a modification, not even a complete change of that, but a modification of the way they do things, and they just can't see the validity of it. And it's surprising to me the amount of pushback we've got. They'll take and look at some of these cases that are smaller and they're thinner, so they think, well, that's a detriment because they're not fat.
Mm-hmm.
And they'll go, well, that can't work. And you go, okay, it can't work. But what about this X-ray I just showed you where, in fact, it did work?
Right.
And they just kind of glaze over at that point in time and go back and they go, well, it can't work. I'm dumbstruck, really, that level of denial exists, but it's ubiquitous in all of medicine. I had a conversation with a Nobel laureate who was the guy that came up with the whole idea of prions, and he got hammered when he first came up with that idea. And I said, what did you do about it? He says, I just kept throwing data at him. Eventually I won. So, you know, it's kind of the way the system works, but it's really kind of too bad.
Yeah,
Well, how interesting, excuse me, the SS White adopted this.
Well, they adopted it because they were open enough to listen to us. You know, like I said, we took an idea, essentially the same idea to another big manufacturer, and they told me to take a hike.
Mm-hmm.
And in fact, they kicked me off of their opinion leader group because of it. But
oh wow.
well, yeah, I mean it's
worked out to everybody's advantage.
But so I think the SS White deserves an enormous amount of credit. They also have these endodontic burrs, the EndoGuide burrs, which used to be Clark Khademi burrs, but way back in the day. And they're an odd, weird little burr that's wonderful for a lot of endodontic access. And we talked them into making those things, or they did. And so they've been very open about responding to the clinicians. And just as an editorial comment here, one of the things that I think people need to realize is a lot of manufacturing innovation in armamentarium is driven by clinicians, and it's manufactured by manufacturers that actually listen to the clinicians and respond to that.
Right.
You know, it's not just the manufacturer trying to make a buck. The good manufacturers are responding to clinical needs, and SS White deserves a lot of credit for that, because they in fact did that with this V-taper system.
Part of the
awesome.
SS White equation was they actually did not have any endodontists that knew something to push back on these ideas, whereas Big Dental had their cadre of endodontists, and Eric and I were basically minor players for them. And SS White, we were the endodontic experts, and they didn't know any better, and they listened
Way
to
back
us.
in the day. How long ago is this?
This is
Well, I gave the first major lecture on this at the AAE in, when was that, 2012? And when you published the article in...
That was 09, but David and I were talking about this, after the first AMED meeting, so this is 03, 04, 05.
Yeah, yeah.
So it's 50. It's
been a while.
Astonishing how long some of these things take.
Yeah.
Yeah.
Oh, I'm sure.
Yeah.
Yeah, that's not an easy process.
And the new generation of endodontists and restorative dentists are a breeze. They're like, you can do that? And we're like, yeah, We love it.
Yeah.
The restorative dentists, the new generation of endodontists, get these concepts right away. They make intuitive sense. I mean, there's almost nothing that gets stronger by drilling on it or cutting away at it. It's the legacy clinicians that are struggling with it.
Right,
very
right.
rare exceptions.
Well, he's an exceptional guy.
The other thing that's interesting about this is if people come up and they say, well, this won't work, and you say, well, why won't it work? He says, well, you can't clean it out, and you can't fill it, and you can't do these various things. And we're going, well, yeah, you can actually. You can't find a canal, right? That's a big one. You can't find a canal.
Cone beam CT changes that.
Oh yeah,
well,
the crystal ball.
Yeah, so cone beam CT, suddenly you can see mid-treatment cone beam.
It's amazing.
You know where you're at.
Yes.
But the latest thing that's sitting out there just waiting to jump on this thing is image-guided accesses, which John will now talk about because he knows.
Yeah, I'd love to hear about that.
So image-guided treatment's been around in medicine for a really long time.
Right.
Some of the patents are 15 and 20 years old, and what's happened is XNAV came out with a product that was designed for implant placement. It's a natural thing for them to do. And so you take a preoperative CBCT, and that goes into the computer, and then you basically place the implant, you drill the implant path basically on the computer screen. And a colleague of mine, two colleagues of mine, Charles Maupin and Steve Buchanan, thought, God, I wonder if this would work for endodontics. And sure enough, it does. The device is astonishingly accurate. I mean, it's fractions of a millimeter in accuracy.
Wow.
So now all of a sudden, we're not drilling access by experience and by feel and reading dental maps. This is planned. You know, on the cone beam CT, this is where I can see the canal, and you draw a line to the occlusal surface of the tooth, and you execute the treatment plan on the computer without, in a sense, even looking at the tooth. It's very, very accurate. And so
how long has this technology been out?
Well, XNAV's been around for a couple of years now.
In implants.
Right.
In implants.
Right.
In implants.
Yeah, I know that XNAV.
Yep. And there are some tweaks that need to be made to happen to tune it for endodontic practice, but the fundamental technologies, now we can drill holes so small you have really trouble filling them,
Right.
So then it becomes, all right, now how do we actually make it look like we did a root canal through 4 tiny little holes in a molar that are less than
You know those TV movies where the fighter pilot's sitting there and he's locking in, and the whole thing. Oh, it's that.
It's that.
It's like you sit there and you look at the screen and you go, oh yeah, drill here.
Yeah, it changes.
Nice.
And it's like the next step past the cone beam. In fact, we had a guy on a blog yesterday. He's saying, well, I had to use the cone beam to find the canal on this. I felt like such an old guy because it's not modern technology. I'm thinking,
my goodness.
Yeah, I mean,
Wow.
he's like, half the people don't have cone beams, and he's already passed that as his paradigm.
Wow.
So this is accelerating very rapidly.
He's a go-getter.
And and then so that's good. That's going to change things. And now the accesses are getting ludicrously small to the place where we're probably going to have to make them bigger just to get irrigation.
Just to say you did something.
Down, yeah, to say you did something. But every time something like this comes up, you end up with the issue of how do we actually apply this in the real world, and where's it going to kind of come out to? Irrigation's another thing. They've got this Sonetto gentle wave system out there that almost is magic, and it will clean canals to the apex just with sonic energy.
Right, yeah.
And it appears to work.
Yep.
It does. We've done a lot with Sun Endo. It's
Right.
an amazing company.
Yeah.
Definitely.
And so
the definition of what a root canal is undergoing some change. I mean,
I hear that.
yeah, it's, we've been applying this technology, and it's been a long process. It's basically been an evolution of doing what we've done better, and now we're doing a fundamental shift in the way we're thinking about
Right.
things. Now the combination of dynamic guided access, DGA, with a device like the XNav, we need to completely reconceptualize endodontic access again, because the combination of that with these incredibly flexible heat-treated nickel titanium files like the V-tapers,
Right.
you can make accesses that have no resemblance to traditional straight line access anymore. And the files will go around, they just don't care. And they're so soft, they don't transport like a larger instrument does. And so we're making accesses. Maupin showed me an access to maxillary bicuspid. It was through the distal palatal line angle into the canal, and he left the occlusal onlay intact.
Well, I had a patient. I had a patient a couple of years
like
ago.
The access was like in and then down, like
Right.
a 90-degree engineered into the access.
I did that on a guy about 4 years ago. He was 90 years old. He says, "You know, Eric, I really like that gold on that tooth. I think you'd have to cut through it." I said, "No, I'll go through the buckle." So I just kind of curved down through the buckle, and I just did it because I liked the guy and it was fun. But you know, we get stuck in these legacy ideas. And the whole thing about straight line access is a legacy idea that's left over from using stiff stainless steel hand instruments in 1968.
Right.
Well, this isn't 1968 anymore, and we're not using stainless steel hand instruments. I mean, we're using second, third generation, very highly developed instruments that they just don't care if they go around corners. So you've got to sit down and let that that straight line legacy idea go. And it surprises to me again how few people just can't. I mean, how many people there are who can't actually do that. They're so ingrained in that.
Okay, doctor, so we're in 2025, and if you could put out a time capsule today into the future, what would your best piece of advice be as an endodontist? This is a fun one, Dr. Herbranson.
Oh, man. Find a place you want to live. Marry well. Have fun with your kids. And stay interested in your endodontics.
Stay interested.
Love that.
Be curious. I think curiosity, it's a two-edged sword many times, but it will make your life a hell of a lot more interesting.
Sounds like you both have adopted the whole curiosity topic in your lives.
I think we've both always been curious guys.
Yeah, we like to know how things work.
Yeah. As kids, were you like tearing things apart just to put them back together again?
Well,
maybe not.
Sometimes.
Yeah, I mean, we have esoteric knowledge in useless fields, which we find very interesting.
Oh.
So,
Well,
which is not the endodontics field we're talking about, but other fields, you know.
that may be a definition of a genius. I don't know. Isn't that what they say?
No.
No.
Plus, we're not arrogant about what we know.
Just curious.
Right. Well, we'll leave it there. And
right.
I want to thank both of you for joining us today. This was really, really a lot of fun and very informative.
Thank you.
You guys have been, your careers disrupting the topic of endodontics, and you're going to continue to do so, I would imagine, for a very long time, right?
Yep. And so we get Prosecco now?
When we're done.
Oh, okay.
We're not quite finished.
Okay,
I
right,
promise you some.
All
We're
right,
going.
okay.
Okay, yeah. Just we got to wrap first. All right. Thanks so much, you guys. Will you come back and visit us again now after you've been here twice already?
I don't know anybody smarter than him, so I can't bring out somebody smarter than him. But he knows people smarter than me.
Ah.
So perhaps we can.
Well, I'd love to have you both back.
That'd be fun.
Thank you. It's been a
Thank you.
pleasure. All right. We'll see you
Always
both
a
very
joy.
soon. Thank you.
Thank you, Lisa.
Take care. So that's going to do it today for another edition of DocTalk Dental. I'd like to thank our special guests, Dr. Eric Herbranson and Dr. John Khademi. And a huge thanks to our sponsor of this episode, SS White. For more information on their products, please go to sswhitedental.com. As always, for more information on everything endo, please visit our website at endopracticeus.com and subscribe to our amazing publication. And to view this episode and more, go to doctalkdental.com. Thanks so much for joining us today. We look forward to seeing you again on the next DocTalk Dental. Take care, everyone.